It's very easy to identify a heart attack. It's very easy to identify a stroke. It's obviously an abnormality. The problem with mental health care is that a lot of the problems are the extreme of a normal experience. It's okay to feel sad. It's not okay to be depressed. It's okay to feel apprehensive and anxious, but having an anxiety disorder is something very different. It's okay to be scatterbrained at times. It's not okay to have ADHD. So it's almost an extreme of a normal experience. And where that line is drawn becomes a little bit nebulous a lot of times. And so it becomes this thing that people just shy away from, or it becomes something that's stigmatized. It carries this weight that, these are just normal things. People should be able to control that. But that's not really the case. And I think that what's missed is this idea that psychiatric disorders, mental health disorders, are brain disorders with emotional and behavioral manifestations. They're not a whimsical thing. They're actual pathologies, actual disorders. They're medical problems.
Welcome back to MasterMined. I'm Mark Scrivner, your host today, and today I'm joined by my co-host and two of the most sought-after consultants in this space, Jeff Skillen. Welcome to the show, man.
Mark, I was driving up here today, and I was really looking forward to what we're going to do. So great to be here as always.
Awesome, man. Always a good episode with you guys. Lee Pepper, thank you for joining us as well.
Mark, make sure you tell the audience that I came bearing gifts this morning.
Oh, you did?
Yeah, that I stopped at Fox's Donut Den and brought in some chocolate glazed donuts.
They're lovely.
That gets the energy level set just right.
Yeah. Well, today we're also joined by Dr. Ali Farooqui, CEO of Healthy Minds. Dr. Farooqui's journey from medical training to leading one of Nashville's most respected psychiatric practices offers valuable insights into modern mental health care. Let's jump right into it. Ali, welcome to the show, man. It's great to have you here today.
Hey, thank you so much. Thanks for inviting me. I'm delighted to be here. I love your guys' energy and rapport, so this is going to be a lot of fun.
Yeah, well, great. Hey, man, just to kick us off today, if you don't mind, maybe you could take the audience through your journey. What got you here? Where all you've been in your background?
Yeah, absolutely. So, I'm a physician, so I'm a doctor. I did medical school at the University of Kentucky in undergrad. So I'm a Kentucky guy. So and I live in Louisville, Kentucky. So my postgraduate journey is a little bit took a few detours. So I started off in neurological surgery, so brain and spine surgery. Did some training there. I left medicine for a little while and delved into the finance, consulting, and business and administration world. And then, I missed my calling. I missed healthcare, so retrained in psychiatry, and so I'm a psychiatrist now.
Awesome. Yeah, well, that's great. Great to have you again.
Thank you.
So, Ali, I think we should probably start off by just saying how we met and one of the reasons that we wanted to have you on the show. So we were introduced by a mutual colleague, Jamie Vance, who many people who are watching and listening to this, knew Jamie. And so if you don't mind, talk about just for a moment about how you met Jamie and then what the original idea was when you guys got started and then what's happening now.
Yeah, absolutely. I mean, Jamie is a very special person and near and dear to my heart. So, like most good friendships and special things, it's a very serendipitous beginning. So there wasn't any planned meet. So I was giving a talk where some of his employees with his previous practice were in attendance. We had a brief conversation after the talk, and I mentioned that I did some consulting for interventional psychiatric practices, and that's my passion, and that's what I do for a living. And so they introduced me to Jamie. We hit it off, and the idea was that we would start a clinic that would deliver cutting edge, top notch care for mental health disorders, utilizing all the tools that mental health care has to offer, and deliver it to patients, which includes interventions and general care. So that's what we started to do, and the way that idea materialized was Healthy Minds.
Well, when we had the opportunity to meet after Jamie's passing, one of the things that immediately was obvious was how unique you are in approaching your practice and then approaching business, because rarely do I find someone who excels in psychiatric practice, but also has just a really keen business mind and has a picture for where this practice could go, what we're not doing, and then what needs to be incorporated into, the modern mental health landscape. And it's really rare to find that in, someone who practices medicine. So I thought that it would be really amazing to bring your perspective to our audience, and then I'd like that's to be sort of the basis of where this conversation begins. So if that doesn't pump your ego up too much, how do you respond to that?
Oh man, it actually humbles me because it tells me that there's a vacuum in medicine for folks who practice that know how the business world works. And when we talk about things like burnout, we talk about things like first responder well-being, first responder trauma. We talk about things like that. I think a lot of the reasons are because it's we conflate burnout with moral injury. A lot of times, the providers, the people who are delivering the care, their values and ideals are separate from the values and ideals of the marketplace of healthcare. And if they're not able to make those align in some way, if they can't synchronize them, then you get things like fatigue and burnout and moral injury and kind of a dissatisfaction and jadedness. So as ego inflating as your earlier statements were, they were actually humbling in a way, because it just shows that I think if we can educate individuals on how to synchronize the values that they hold as treaters and healers with the values of the system at large, then we can probably work toward a better system of healthcare delivery.
Go ahead, Lee.
Yeah, I was going to say, Dr. Farooqui, I love your brand. I think Healthy Minds is such a positive branding exercise you guys went through, because I think in the addiction space, it's so difficult having these conversations because people put their morality into the crisis that the patients are having. So I want to congratulate you. I think that's a positive affirmation when people are coming across. How did you guys come up with that name?
That's a wonderful question. So brainstorming is one word to describe how we came up with that. But it's we wanted to focus on what our values were. The value isn't, and it needed to be personal to somebody, right? So you can have a very cut and dry branding for individuals, but it doesn't really resonate as to what the patient wants. So for example, if I have something like, better psychiatry, well, that's speaking to me, that's not really speaking to my patients. Because my patients don't want better psychiatry. They just want to feel better. And there's a difference in what we are communicating with a name like that. And no offense if there's a practice out there called better psychiatry. I have no idea.
No judgment.
It's just something that came to the top of my mind.
So Matthew, watch for the hate mail.
Yeah, exactly.
That's right.
Hopefully Jeff and I didn't work on that time.
But so and one of our values, so and the folks that work in our clinics know this, and they have heard this ad nauseum from me, but there's certain maxims in our practice, and one of them is how we approach the delivery of care. And what we do is we treat the person and their brain, the disorder, and its symptoms. So the Healthy Minds wording and that combination came from that idea that the person has a brain, and we treat the person and their brain. The symptoms that a person experiences don't belong to them. They belong to the disorder. They belong to the problem. They don't belong to the person. And so the idea was to remove that negativity, that stigma, if you will, or that barrier towards getting care, and focus on health, not focus on the problems.
Well, I think that's why that name resonates so well, is because you did the underlying groundwork first. So many times, Jeff and Mark and I have been involved in a lot of different marketing initiatives, and a lot of times the folks want to start at the top. Let's just start coming up with names. Mm-hmm. And even today with ChatGPT, I mean, they go crazy with the names. Now it's like, okay, no, let's maybe start at the bottom here. Let's figure out what our root is. So I congratulate you and your team, and how that resonates. You talked about with your staff. Like, now the staff know those building blocks versus that's just the name.
Mm-hmm. Well, a lot of people, especially that listen to this podcast or watch us on YouTube, they're building their own programs, or they're thinking about building their programs, and so you sit in a really unique spot where people who are building those programs, a lot of times they see psychiatry as we need to have it. It's kind of a bolt-on, right? But you're sitting in a space where it's like, what the other side of that wall is. What are the limitations of the way people are, when they typically think about psychiatry? What are the limitations as you as a provider? What are they? And then what are you trying to change?
That's a great question. I mean, you can argue that's $1 million question in healthcare.
100%.
Because, there's a reason that we have a mental health crises right now. There's a reason that people are placing value on their emotional well-being that's equal for the first time, I think, in ever to their physical well-being. And one of the reasons that we see a little bit of a disconnect, or historically we saw the disconnect, is because people don't really know what causes things that impact them emotionally. And to be honest with you, the research is still ongoing. I mean, we don't have an exact idea. There's theories, and we test them and we improve upon them, but it's very easy to identify a heart attack. It's very easy to identify a stroke. It's obviously an abnormality. The problem with mental health care is that a lot of the problems are the extreme of a normal experience. It's okay to feel sad. It's not okay to be depressed. It's okay to feel apprehensive and anxious, but it's not. But having an anxiety disorder is something very different. It's okay to be scatterbrained at times. It's not okay to have ADHD. So it's almost an extreme of a normal experience, and where that line is drawn becomes a little bit nebulous a lot of times. And so it becomes this thing that people just shy away from, or it becomes something that's stigmatized. It carries this weight that, these are just normal things. People should be able to control that. But that's not really the case. And I think that what's missed is this idea that psychiatric disorders, mental health disorders, are brain disorders with emotional and behavioral manifestations. Mm-hmm. They're not a whimsical thing. They're actual pathologies, actual disorders. They're medical problems, but the symptoms are behavioral and emotional. They're not physical. And I think that recognition is really that recognition of that reality is really the first step to syncing mental health care and brain health, healthy minds, with the rest of human health and person health.
Yeah. Well, Ollie, I mean, that's a great point. And, I know you're from Louisville. What problem or opportunity maybe did you see in the Nashville market to want you to come down here and launch Healthy Minds in Nashville?
Well, Nashville, I love Nashville. So I love Louisville. I'm a Louisvillian, so I'm even though I don't pronounce it correctly, much to the chagrin of my wife and her family who are from there. So, Louisville is what they say. I still say Louisville.
You need to relax the tongue a little bit.
Yeah, I know.
We'll have an episode just on those kind of towns, There's a lot in Tennessee that way, too.
Yeah, sure. Yeah. But, Nashville was special in a few different ways. The first is that the population of Nashville is growing. There is a appetite for well-being that's a little bit more upfront than in a lot of other communities. Jamie is from here, And so I didn't want to deviate too far from, his silo and the place that he felt that we could make an impact. Could our practice do well in other populations? Absolutely. But in terms of where we wanted to start, where we could have a widespread impact and we could make a change in the way that we wanted to, Nashville was a perfect mix. The size of the city, the population, the growth, the diversity here, the different communities in Nashville. It made sense to start here.
Yeah.
So from a business perspective, you're looking at sort of outpatient services, traditional, psychiatric practice, but what is your vision for not only what you're currently doing, but where it could grow, and what do you think the future looks like in terms of those services?
The services, are. I try not to cap us by saying that this is specifically the type of practice that we are, because doing that would limit us. Psychiatry is ever growing, ever expanding. The scope of psychiatric care and mental health care involves medications, hospitalizations, therapy, social work, community work. It involves addiction care and the entire, array of various addiction options. It involves health, general physical health stuff. We know that physical health complaints have emotional consequences, and so it's a really wide spectrum. And then the way that we treat mental illness can be just as varied as the different types of mental illnesses that there are. What was important for us was to have a unified culture and approach that allowed for us to stay true to our roots as what we are, which is a medical practice, that allowed for us to evolve with the changes in the science and changes also in culture, and to stay as evidence-based as possible. We wanted to have data to back up what we did. We didn't want to go off and do things that didn't have any backing. We wanted to feel the confidence, and I wanted my providers to feel the confidence that when we recommend a treatment or when we offer a treatment, we know that there is data and a track record of these things being, successful and these things working. And that's what was important to us. But what I think the question that you asked goes into the second axioms. The first was the persons and their brains and the disorder and its symptoms. But the second is that I told all my providers, Jamie and I talked about this, and all of our, including our administrative staff, know that the goal is to get an individual as well as possible, as fast as possible, with as little as possible, and to use all the tools in our arsenals to get them there, and that good enough is not good enough. And that's the goal, right? Good enough is not good enough. We're not stopping until the person feels like they're well. We are getting them as well as possible. That doesn't mean that they feel not like themselves. There's this impression that good clinical care, good psychiatric care means that you'll be quote unquote drugged out. That's not the case. We want our patients to feel like themselves. We want the well-being to feel natural, not artificially created. And we'll use the tools to get there, and we'll do it fast, and we'll do it effectively, and we'll get people feeling like themselves.
I want to stay on this topic for just a moment, because if you zoom out a little bit, I think what a lot of people experience when they're seeking services or just investigating this. Let's just go to supply and demand for a moment, okay? So if someone is seeking services, their typical experience is that they want to use their insurance, and they'll be like, great, we'll see you in 9 months, right? So there's a super long wait. And then I'm curious from your perspective, it's like from a demand side, it seems like there's tremendous demand for the services, but yet are there too few providers? How do you see supply and demand in this space, and then how do we address that?
That's a great question. So The access problem, I think it's a multimodal problem, because you have the issue with payer source, right? So you have providers that are private pay that don't take insurance. You have providers that take some insurance but not all. You have providers that take Medicaid. You have providers that take Medicare. And so depending on how I am going to receive this care, I'm already siloing myself to certain buckets of the healthcare market that I'm able to go to receive the care. So that's issue number one. Issue number two is that the system is incentivized to stay busy. It's not incentivized to deliver quality care. And so when the metrics that you have for what makes a clinic successful is number of patients seen in a day and turnaround of patients, and that's your metric, then you automatically create a environment in which a new patient will not be able to access care. Because if I don't want to be fired or go out of business, I have to keep a full practice. If I keep a full practice, that means I can't see people easily, and I can't have too much flexibility to allow for folks in, because I'm full, right? That's why you have to wait until when I'm not full, which is usually 3 to 4 months later, because the average time frame for a psychiatric follow-up is 3 to 4 months. So that's why it takes 3 to 4 months to get in, because that's when the schedule is open. So that ties in to what you're saying. So how do you solve that? Is there a way to solve that? A lot of folks have tried, value-based healthcare systems, et cetera. Does it work? Kinda, not really. It's not a perfect system because you're still trying to change from within. And so you have to keep some of what's not working in order to change, right? It's kind of like, it's kind of weirdly enough how government works sometimes. You try to make slow change from within, and sometimes can be, people can get impatient with that. So what do? So we don't penalize our providers for not being full. So our focus is on quality, and so we are quality oriented. We are not appointment oriented. Okay. Does every business have to track appointments? Absolutely, right? But the focus is not that. You don't push for that. You work on that on the back end, but that's not what the people that are delivering the care hear. They will never hear, we need more appointments. What they'll hear is, how do we do better? And so that cultural change is really important, because one of the things that we've been able to do because of that cultural change is have spots in our scheduling metrics that are open to accommodate emergencies and new patients and people leaving the hospital. We don't want our waiting time to be more than 10 minutes. Everyone's time is valuable. If people give a lot to see a doctor, okay? Sometimes they have to take a day of PTO or a half day of PTO, and they have to arrange for childcare perhaps, and it's disrespectful to patients and to people if you have them then wait 2 hours or more beyond their time.
I need to stop you there just for a second. How refreshing is it to hear a doctor talk about respecting their patient's time?
I was just like, oh, thank God.
Sorry. Sorry to interrupt you, but it's just like it's unique to actually have that perspective.
Well, and that was the whole idea behind what we wanted to create. Is we keep it person oriented, right? We treat people and their brains, and we treat their disorders and its symptoms. And so we that's who we are treating. We're treating people. So we have to respect individuals' times. You have to respect the fact that when someone is sick, they will be impatient. So we have to see them as soon as possible. We have to at least provide that degree of hope. We might not be able to treat them day one, but they at least need to be evaluated, assessed, get a plan of action in place so that folks know that they're cared for. And that's what we're about. That's the metric, and there's ways that we can measure that. And I think that if we do that well enough, which we have been, then what we get is loyalty and trust. And healthcare is about trust. You're not going to go see any person who you think is going to do a bad job, or you feel like you can't trust their decisions or their care, or you feel like they're motivated by something other than what is best for you. And so that's really what we focus in on.
Are there physician's assistants and nurse practitioners in psychiatry?
Oh yeah, absolutely.
And so like if a patient comes in and they're meeting with you the first time, are they doing follow-up visits with PAs and nurse practitioners?
So the PAs and nurse practitioners, it's called the moniker for that is APPs, Advanced Practice Providers. They can deliver healthcare from start to finish. The idea, at least in our clinic, is what's the environment in which that person is practicing. So, for example, we meet as a team. The clinical team meets sometimes weekly, sometimes monthly. So I meet with each of our employees or providers, NPs, weekly when they start, but no less than once a month to do education, discuss cases, et cetera. So we want to create an environment where folks are always growing, because the difference in terms of a care that's delivered by a physician and a care that's delivered by a PA or nurse practitioner is experience. There is something to be said for the almost decade of formalized education and supervision that is received by a medical doctor. But the reality is that the healthcare needs of Americans is too vast for physicians to be able to accommodate that. Now, can we train more physicians? Yes. Would that solve the problem? No, because there's varying tiers of acuity. So not everybody needs to necessarily see a physician every single time. So what we do in our practice is we change the roles. So in our practice, the physician's the coach or the quarterback. So we quarterback the care. We direct the care. We set the plays, right? But the people executing it are the folks that are providers. If I'm in the front lines providing care directly 100% of the time, then I can't really, I won't have the bandwidth to be able to use the education that I've received to allow for our PAs and NPs and other folks to help patients as well. I can't do that because I'm too busy treating the patients that I am directly responsible for. So my role in our company is one of leadership, not one of clinical care. So I don't see patients directly unless it's a complicated patient that one of our providers asks for my assistance with.
Or if we text or call you after this.
Hey, absolutely. So, but and that's on purpose. That's because it's what the value is, right? So I can make more of an impact by educating a number of providers in how to deliver the best quality care and then being always available 24/7 rather than going and seeing one patient at one time. So that's kind of how we do it. And the key there is you got to be available. You got to be there to do it,
Yeah, Ali, this is, really refreshing to hear you say this. From the intake process to the way you run it, where did you learn this? Like, was it from being a neurosurgeon to, how did you come up with this to do it different?
It's translational learning. So it's not any one area, and it's not to say that people aren't doing this. I think that folks are, but it's just not, for a lot of people, all of these things might not be intentional. They stumble upon it and it works. And when that happens, at least for me, if I'm trying to, cook something or whatever, and I stumble upon a great recipe, I can't tell you how I did it. If you ask me to write down but I can repeat it, but I can't. Yeah. I can't actually teach you how to do it. And so it's just bringing things that I learned and picked up from people who are doing it well, some better than me, admittedly, and just trying to mix it all together to create something special. So it's not just from there are aspects of my neurosurgical mindset. There are aspects of, my mentors in business and administration and finance and psychiatry for sure. And, my dad, my wife, my friends, you just kind of bring Jeff and you, so I bring everything together in an intentional way. So I think intentionality is the where I'd go with that.
Well, it's very refreshing. So
yeah,
thank you.
I mean, I think you've addressed sort of the supply side now in terms of meeting the demand and the unique way that you do it. Now let's go a little bit further into I think the people listening, they're going to want to know about. Let's talk about ketamine.
Yeah.
Let's talk about TMS.
Yeah.
Let's talk about Spravato and talk about the various things that are buzzy. People are talking, and it's like, so is it buzzy because it's good, or is it buzzy? What is your perspective in terms of like where this is going in terms of services offered?
A little bit of both. So it's buzzy because it is cool. Let's be real, right? There is a mystique around psychedelics and mood and mind altering substances. There's movies and books and about it going back. There's a history behind it as well. So yeah, it's buzzy because it is cool. It has a mystique. It has a certain capture into the imaginations and the possibilities of patients, but it's a treatment. And I think that's what needs to be remembered. There is failure rate, even for psychedelics. We don't talk about it much, but if you look at the data, there is a failure rate. Not everybody responds to psychedelics for both PTSD and for depression. And so that's the part that's, I think, missed a lot of times. But why is it interesting? Why is psychiatry taking a hold for it? Because it challenges the dogma of how we treat psychiatric illnesses, right? So if you think about how we structure and formulate and understand psychiatric disorders and psychiatric conditions, they're very symptom-oriented. And it feels like for a lot of our patients that the treatments don't address a root cause. It feels like for a lot of our patients that the treatments are just superficial and they scratch the surface, but they don't actually address what's going on. And while some of that is true in the traditional practice of medicine with medications, that's not all the way true. Just because we can't articulate in an easily digestible way why a medication works doesn't mean that we don't know and have theories that are pretty robust about why something works, but it just might not be very easy to convey. And so the lean then for the patients is, well, what do I understand? People understand psychedelics. They understand ketamine, right? TMS, they don't understand as much, the neuroscience behind it, but I mean, God, think about the attraction of that.
Right.
No medications. It's not going anywhere in my body except for the organ that is impacted by my illness, which is my brain.
Right.
I can stimulate it kind of like a pacemaker. I can stimulate my brain and pace it, kind of like what people do with their hearts to address a problem. And great durability, meaning that after I'm done, I have a response that lasts beyond the treatment. It sounds like a godsend. And it works really well. I mean, we love our interventional approaches, and that's what we are. And that speaks to what I said earlier, is that we use all the tools in the arsenal. The patients deserve better. They deserve to be able to get anything that would help them, that would treat them. Let me rephrase that, not necessarily just help them, that would treat them. Mm-hmm. And so we want to be able to provide that. And that is our goal, and that is what we do, is if there is a treatment modality, whether it's dogmatic, but if it works, it's got good data behind it. I used to have a phrase called abandon the archaic, but I changed that to scrutinize the status quo. I like alliteration, No.
Well, so I'm going to meet you in alliteration for just a moment, okay? Mm-hmm. So does buzzy lead to breakthrough?
It can. It certainly can. Yeah. It depends on who's on the driver's seat, in my opinion. So I think that if you have something that's buzzy in the hands of somebody who is reasonable and thought out, and is planning with the idea of patient care and well-being, and not just breakthrough for the sake of breakthrough, then I think that it can certainly be a bombshell of development.
Because I think a lot of people are looking at this space and they do see the shift, albeit slowly, from archaic to the new thing. And it seems to me like you're sitting on the cusp of that, but I mean, maybe that's just my perspective.
Yeah.
I mean, what do you think?
One of my mentors said that in medicine you don't want to be the cutting edge, you want to be the bleeding edge, and I like that phrase, right? So because the cutting edge is unproven. We don't actually know what the long-term outcomes are going to be. We don't actually know if this is going to be effective in the way that we want for the people that we treat. But the bleeding edge, you have something to rest on. You have a certain degree of reliability and a certain degree of expectations. Look, I tell folks this all the time. I'm 100% sure that I can treat patients. That we can treat people. We can get them well. I'm 100% sure of that. The challenge is to find the treatment that's going to be the most effective for them, the most direct treatment, right? That's why it's so important to have as much as possible, to have as many of these proven track record, tried and tested, well-studied modalities, because you want to be able to select individuals well. And systematically, that's difficult to do, because clinics, you have to have it. There's an educational barrier. You have to learn what the new approaches are. There's a reason that the familiar is comfortable. It's because it's familiar. You like your mom's food, even if your mom's cooking was horrible, because it's your mom's food. Mm-hmm. And it's a little bit more difficult for you to try something different and new, even though it might be delicious and your palate might love it, but it's different. And so the familiar is always going to be comfortable. And so there's a significant familiarity bias. There's a significant educational bias. There's a significant capital obstacle there too, because a lot of the treatments, they require investment into the clinic to see any kind of a return. And and that might be delayed. This is healthcare, man. We don't, you don't pay at the door. You pay when you leave the door, go to bed, wake up the next day, and maybe a couple months after that. And that's when the services are paid for. And so there's these barriers that are intrinsic to the system that limit the advancements in the clinics as they exist. So the challenge of then being able to provide everything to our patients is what we wanted to address. And so the identity of Healthy Minds, like what you're saying, is an interventional clinic, mm-hmm. even if we practice general medical care. We're not a service line clinic. It's not like Valvoline. No, you can cut that out if there's a trademark issue. But it's not like one of those places where you go and get one service and then leave. No. The idea is you get full service with everything that works. And so we allow our providers to be able to determine what's best for you and then give that.
A lot of the conversation so far has been on interventional services, which makes perfect sense. I'm curious on the other side of that in terms of diagnostics. Is there anything buzzy or interesting on the diagnostic side, or is that just kind of still a little sleepy?
There's, I think, a lot of really cool things on the cusp for that. So there's some that I'm not allowed to talk about because of contractual obligations.
This is the perfect. Ollie, we have an opportunity.
Here, we're turning the mics off. Tell us.
This is your launch pad right here.
You have an opportunity to break some news right now.
But there's been a lot of development in what the next wave of diagnosis looks like, because so far there has been no wave. It's been kind of Lake Placid, all right? So it's been the same thing. It's been questionnaires, right? The most diversity that you have in the questionnaires is Does a patient filling out the questionnaire, or am I filling out the questionnaire for the patient? That's about the only complexity that you'll get, but it's all questionnaires. So with neuroimaging, functional neuroimaging, with EEGs, and then the marriage between the two as well, EEG, fMRI, combinations, et cetera, we can look at some pretty cool things on the horizon. So
I'm going to give you one more opportunity, actually.
Well, I don't think that it's. I don't want to be the person that the podcast that didn't age well. The only episode that aged poorly. All right, so cautious optimism, but definite optimism.
Well, I'm just encouraged that there's some real work and effort in that regard, because I mean to me that just seems still like a very archaic model.
Absolutely, yeah.
How about virtual care in your world? Where are you seeing it providing the most value, and then where is the in-person as a must?
Oh man, great question, and very time appropriate too, because that's been a debate nationally about whether to allow reimbursement for virtual care or not, and how to monitor that, and what are going to be the limitations of that. It's vitally important because it's my partner in Louisville has a joke. It's can you really be mad if someone doesn't show up for their appointment? They're sick. Of course they might not show up. They're sick. And so that's the idea, right? That's where virtual care comes in, right? Because you should not be expected to significantly go out of your way to get care when you are sick in the way that doesn't allow for you to go significantly out of your way to get care, right? And we're talking about emotional things, right? You can't have an assistance like a physical disability. Thank God that there are services that will assist you, right? Wheelchair folks come, transport you to your physician's office, your doctor's office, your provider's office, and you can get care. That doesn't exist for emotional and behavioral issues, right? You can't really get outside assistance. So the expectation, it's just it kind of handicaps folks. It puts them in a bad spot. But virtual care solves that problem because you can deliver care no matter where the person is, and that's huge. That's huge because think of how easy it would be if you are somebody who's on the clock for you to go into a quiet office during your lunch hour and see your doctor instead of taking a half day of PTO. Right? That's huge.
Well, and you mentioned childcare earlier.
Yeah, childcare.
Childcare,
another one. Right? And think about travel time. Think about if you are financially strapped, the economic times are hard and they fall harder on some individuals than others. Gas money, traffic time, pay for parking, getting back to work, all of those things can add up and create those barriers, right? So we do both. Our intakes are in person because that first impression, the first approach to a person, I think you lose a lot by not having the ability. Now, are there exceptions? Yeah, of course there are exceptions. There's no such thing as a hard and fast, concrete rule. But but generally speaking, we prefer our intakes to be in person. But then we go based on patient needs, right? And that's the part of the culture, empowering the providers to be able to make that decision. Is this somebody that we need to see in person frequently, every single time? How often? Is this somebody that we're comfortable seeing, in person once a year, twice a year, but the rest of their appointments, they can be virtual for convenience sake so that we don't have a gap in delivery of care?
Does Healthy Minds provide free parking, though, if I come visit?
Yes, we do.
Okay, all right.
Absolutely, absolutely. But those are the logistical things that I think were really important. Because interventional care, you mentioned TMS, you mentioned Spravato. You can't. You need parking, because if I'm going someplace to get TMS treatments, which for the audience is transcranial magnetic stimulation, it's a FDA-approved treatments covered by most insurances. Spravato, same thing. That's intranasal ketamine. It's a product that's FDA approved for depression as well. So if you're getting those treatments, your frequency of going to your doctor's office is greater than going just to see the doctor, right? So TMS is 5 days a week.
How long are the sessions on TMS?
Like 20 minutes.
Yeah.
It ranges, but if you were to put a hard number on the max amount of time, 25, 30 minutes max. So, if my commute time from parking to my treatment is 15 minutes, then it doesn't matter how long or short my treatment is, right? But if I can park my car, walk in, get my treatment, walk out, and leave door to door, leave, get treatment, come back within an hour, that's worth it to me. If it's going to take me 2 to 3 hours to do that, that's not worth it to me. And so we kept those things in mind. When we selected our locations, when we selected the real estate, we kept those in mind. We wanted ease of access. We wanted folks to be able to park and walk in and leave on at will without any wasted time.
Yeah, your passion around this is just amazing. And, this has been a great show. I don't want to close up before we talk a little bit about just, your vision the next couple of years. What are you the most excited about with Healthy Minds? Like, where do you see yourself going as a company?
I think what I'm really excited about is how we can impact and change the culture of healthcare delivery. We said this a couple of times already. I think people deserve better. And that's what we're trying to do, right? I'm not arrogant enough to say that my way is the best way, but we try to do better. We try to evolve and not just kind of rest on our laurels. So we want to do better. We think there is a better way to do things, and we're trying it. And we're flexible enough that if our way doesn't work, we will find another way. And we will adapt, and that's okay, because the goal is to treat individuals in the best way, in the highest quality way, and to secure the trust and loyalty of the community. So where we're going to go is we want to be able to deliver that level of care that people deserve to communities and to populations outside of our radius of where our clinics currently are. So we want to grow. We want to do it in a way that's accessible. So we don't envision ourselves as being a department store. We envision ourselves as being a coffee shop. So, we have low footprint, high quality, and the ability for it to be a third space where you can sit, and the ability to drive through, right? So a department store is a commitment. Going to a coffee shop is not. And so we want it to not feel like it can be a part of your day. It doesn't have to be your day, right? So that's why we need to have the right type of growth. It can't just be, we just want more people. We just want more business. That's not what it is. It has to be the right kind of business so that we are giving something to people that they need, that they deserve, that they want, that will actually be convenient and easier for them to get their health care. So that's our next growth. And as things, as that happens, then we will continue to expand the types of services that we deliver. So right now we deliver medical care and interventional care, and we will do that. And as we grow, the next, we might not do it at every single place at every single time, but we will add to that as we grow so that all of our patients get the best quality care that we can provide.
Yeah, we touched on it briefly right before the show about AI, and maybe you could just talk for a minute about like how you see it impacting what you're doing or aiding in, being able to provide even better care based on AI.
We had such a nice conversation about that before we started, but I think it would be wise and it would be irresponsible not to to talk about the fact of what AI actually is. It's not the clients where you prompt and you receive a response, right? That is one use of AI, but that's not the umbrella of AI. So, AI is a tool that can be used to speed up processes and tasks that are labor intensive for individuals. So where can we use that? Well, let's talk about front end to back end, right? Where AI makes the most sense for a business like ours, for a clinic like ours, is actually more on the back end stuff, right? Speeding up things like patient appointments, wait times, our system of our billing, our logistics, our reporting, our revenue management, our understanding of our revenue, find the blind spots that we're not able to see that would require a lot of manual work that we can automate, right? Go one step further. What are the things that are redundant and administrative in nature that don't necessarily require the intellectual prowess of my providers, right? So can I automate things like billing? Can I automate things like coding? Can I automate those things like that, right? Can I make them intelligent? Because you can automate them, but they're not necessarily intelligent. You still have to double check, right? Can I make them intelligent enough that I can at a cursory glance know that this is happening in a compliant, appropriate, legal, ethical way, all the way down to how the clinic flow works, right? How do I schedule these 7 providers with different service lines, whether it's, Spravato, Ketamine, TMS? How can I structure my clinic and my staffing so that it's the most efficient for people to reduce wait time, so it's things like that that I think will have a immediate return on investment of utilizing AI. Then you take it a step further to actual the administrative process of healthcare delivery, note-taking, lab value sorting, things like that. And those products already exist. A lot of them are integrated into a lot of electronic medical record systems. The final step for that is what I don't think we are ready for, which is actual delivery of care. And I don't know when we will be ready for that, but I know it's not now because there's so much context, that I think it's that right now seems to be hinge on human interaction.
Yeah. Well, this was such a fascinating episode. Is there anything before we wrap, anything maybe that we didn't ask you or that you'd want to tell the audience?
You guys have done this before, huh? It's not your first rodeo. So
it's as Jeff says, not a hobby, right, Jeff?
That's right. It's not a hobby.
This was a great conversation, and thank you guys for giving me an opportunity to come and a platform. I care about this stuff. I think it's really cool. I think that psychiatry deserves better than some of the press that it sometimes gets. But it's getting there. I think that the population and Americans and people in general are recognizing the need for what we provide. So thank you guys for facilitating that.
Yeah, thank you for coming.
You bet. Thank you.
Well, thank you, Ali. And if today's episode sparked any interest, please rate, review, and subscribe to MasterMined so that we can get our message out to more people. From us, that's a wrap. We'll see you next week.
That wraps up this episode of MasterMined. Thank you so much for joining us. And remember, MasterMined is not just a podcast, it's a community. So don't forget to comment, subscribe, and review us. Your feedback helps us continue to bring you content that's relevant and relatable. Thanks again to our sponsor, Snapshot, a digital media marketing agency. And thank you for joining us on MasterMined, your behavioral health playbook.